India has reported more than 347,000 new cases of COVID as of this Saturday, the third day in a row that the country has set a world record for infections during this COVID-19 pandemic. The related death tolls for the previous 24 hours hit 2,624, also a daily record for India, which is recording about 189,000 fatalities. The skyrocketing COVID-19 infections have been devastating families and communities and even hospitals in India, and everything is in short supply. You're welcome to today's episode of Public Health in Real Life, a channel where we hope to inspire the next generation of leaders, shed light on key global health issues, and inspire young men and women in the field to make the world a better place. I'm introducing my co-moderators for today, Keshav and Ashwin.
Hello, everyone. Thank you so much, Maimuna. As you say, this is really supply chain has a prominent role in global health, and we are thrilled today to have Dr. Prashant Yadav to talk about the challenges we are facing with supply chain management when it comes to delivery of equitable healthcare throughout the world. And with no further ado, I would like to introduce our esteemed guest, Dr. Prashant Yadav, who is a globally recognized scholar in the area of healthcare supply chains. He is a senior fellow at the Center for Global Development, an affiliate professor at INSEAD, and a lecturer at Harvard Medical School. He is the author of more than 50 peer-reviewed scientific publications on healthcare supply chains, and his work has been featured in prominent print and media outlets. In addition to his roles in academia and think tanks, Dr. Yadav serves on the boards of social enterprises and nonprofits working on healthcare supply chains. Dr. Yadav also serves as co-chair of the National Academy of Medicine International Committee on Advancing Pandemic and Seasonal Influenza Vaccine Preparedness and Response, and is a member of the Lancet COVID-19 Commission Vaccines and Therapeutics Task Force. He is trained as a chemical engineer and holds a PhD in management science and operations research. With no further ado, let's welcome Dr. Prashant Yadav. Welcome to the show, Dr. Yadav.
Thank you, Ashwin. Thank you, Mamunat, and thanks, Keshav, for joining us. It's a great pleasure, and thank you for inviting me. And first of all, I want to congratulate you and commend you for bringing very varied perspectives on how people contribute to public health. And I think it's important for a lot of your listeners, viewers, and young people in general to acknowledge and internalize that the ways to contribute to public health have very varied and sometimes pathways that are that require you to go back and forth between different kinds of functions and roles. And mine has been unusual as well, and I'm happy to share about what got me into this area. But hopefully that conversation helps others who want to think about their training and how it can be best put to use for public health.
Truly appreciate that. Thank you so much, Dr. Yadav. And perhaps we will start our interview with the situation in India. And in the past 24 hours, India has set a record with 300,000 plus new infections, and over 2,200 died. And the new infection rate at this point is about 16 million. There are multiple severely ill patients turned away from hospitals. There is a lack of beds, ICU beds, and of course, the big elephant in the room is severe shortage of oxygen. The doctors, mostly from private hospitals, turn their blame to the government on misquantification of the oxygen needs. And of course, this the second wave has been a surprise to multiple industry experts as well. But from your opinion and your observation, what went wrong?
Yeah. So Ashwin, I think it's hard to know what went wrong when demand surge of the type that is now being seen in India occurs. Because yes, it's easy to say we could have planned better, but that's mostly us thinking in retrospect and saying we should have built more capacity for oxygen or more capacity to distribute certain therapeutic options that are administered intravenously and so on. But I think what this highlights is a larger and a bigger question, one of which is we will always have uncertainty of demand for things that are needed in a public health emergency. And how we create an upper bound on what those demand numbers could look like, what can be the real extreme demand surge, whether it is for oxygen or for therapeutic options, that is essentially an area which we all have not necessarily done a good job. And we all here is not just the government of India or a particular state or a particular national, supranational, global agency, but us as a collective community. So when we think about forecasting demand, we have two types of approaches that we typically talk about. One is looking at data on what is getting used and what is the consumption rate in a given hospital, in a given clinic, or in a given health post, and then build from there to see what will be the future demand, and then create a supply plan to meet that. That can only work in routine times. Of course, that's not accounting for any large demand surges that have occurred, for example, during the pandemic, both in India, but also in many other countries, Brazil, earlier in Europe, and also here in the United States. So I think when we think about how to create the right estimates for what could be needed, we then have to draw on epidemiological models, which are based on assumptions, and we learn, and new science helps us revise our estimates. But one part where I think people don't internalize very well is when you are trying to build a supply plan to cope with an epidemic or a pandemic, it doesn't help when you try to respond when you have already hit the exponential portion of the exponential curve. And it is possible to sense when you are about to hit the exponential portion because you start seeing a slight uptick a few weeks before that. And that's the time when you can very quickly say, my demand estimation methodology, my surge capacity now needs to switch into emergency mode because I have already detected the upswing. And I think that's where the planning preparedness phase did not work as well in India, for which we are seeing the effects of that, but similarly in other countries. So I think it's a reminder that in public health, we can be working on a specific function. I can be the person who works on building supply plans, but I cannot do my work disjointed from a thorough understanding of epidemiology. And neither can anyone who is working on policy matters in government, people who are generalists and are brought in as generalists to advise government on response strategies, oftentimes are disconnected or not as thorough in their knowledge of how disease epidemiology, how disease transmission occurs. And I think bringing that back into every function, whether it is supply planning or manufacturing or distribution or transport or logistics or running the hospital operations, that's, I think, a key lesson we take away from the pandemic, both the current situation in India, but more generally as well.
Yeah, and that's where even the bottlenecks are occurring. And whether it is intra-state border issues or like not sharing resources with the other states, or even not following experts' advices. Governments not. This is an issue not only in India, of course, in other parts of the world as well. Um, of course, the United States is one of the gold standard example for that, where the until like maybe the last administration, perhaps where the scientists' voices were not as much followed or put into like policies and driven the pandemic response. And one other issue we have seen in India is with substandard products. There's a report of an oxygen tube leak in a hospital in Maharashtra where 20 people have died, and there was also a fire accident in another hospital nearby. And we also hear about ventilators malfunctioning. So supply chain is, of course, about taking products from point A to point B, but also ensuring that the supplies, while it is at point B, that they are maintained and well kept. So, how how large is the issue of substandard medical products in global health?
Yeah, firstly, Ashwin, I would say the definition of supply chain management has sometimes been misconstrued and thought of as narrower than what it truly is, right? So if we think about supply chain as the function that is about taking a product from point A to point B, that's just the transport, logistics, distribution, and the physical distribution part. But we know that the function of supply chain management is much wider than that. It has the core role of ensuring high quality of products that are moving through the supply chain as both a core function, but also a function that is closely tied and adjacent to the logistics function. Secondly, supply chains function when there are three very closely synchronized flows: that of information about what is needed where, also information flowing back as to what has been used where, also about financing. When will money become available for procurement, for tendering, things like that? And then, of course, the physical flow. So I wanted to start by saying that that's the sort of wider definition of supply chain management
Okay.
you got to think about. Then your question on poor quality and substandard products, whether it is medicines, medical products, perhaps even vaccines. I think the key part in that is you will always have some unscrupulous agents in the market when demand and supply are not matching appropriately. Then someone will enter the market to say, I see an opportunity to supply something, right?
Yeah.
And the best way to avoid such instances from occurring would be if the supply of high quality medical products is expanded. And if that matches the demand, then we will have fewer instances of poor quality. The second part is that when we think about quality regulation, whether it is for medical devices, equipment, medicines,
Right.
oftentimes the function of quality regulation is viewed as evaluating clinical trials, evaluating uh, clinical dossiers of whether a product is
Yeah.
efficacious, safe. But there is an equally important function of enforcement of standards, which means an inspector who can go and visit every manufacturing site and make sure that they are building and manufacturing things to the standards. And that function is often hugely neglected in lower
Yeah.
middle income countries.
Yeah.
And in cases where it's given its importance, it is embedded in a much closer relationship with local government.
Yeah.
And when you say local government, means the incentives of a locally elected leader in any country are more aligned towards protecting any industry which employs, let's say, thousands of people in
Yeah.
their constituency. Whereas the overall population's interests are about making sure that whatever gets manufactured at that plant, that site, adheres to the highest standards of quality. And sometimes this incentive misalignment from what the local government is seeking in industrial policy versus what we're looking for overall population health, safety, quality, remain disconnected, which leads to incidents like the one that you described. And yes, they become more prominent in instances where there is a demand surge, but they are very routine occurrence, right? I mean, we see poor quality medical devices, medicines, somewhat prevalent in many countries.
Yeah. And you touched on supply chain security a couple of times, where, we hear about news of supplies being stolen. Pilferage has been an issue that global health has been fighting for years now. But the pandemic has, as it has highlighted many other issues, it has highlighted the issue of pilferage. So, do you see a need for increasing not only studies but implementation of measures to ensure security of medical products and equipment throughout the health supply chain?
Yeah, it's an important area, Ashwin. So when we think about security in the supply chain, there are two dimensions to that. One is what falls in the area of cargo theft, which means a shipment that is going from point A to point B gets stolen, diverted, sold into a different market. And yes, that occurs in routine times as well, but the occurrences of that are relatively small in routine times. When you see the kinds of demand surges that we are seeing now, yes, that becomes much more amplified, and yes, shipments keep getting lost, cargo theft becomes more common, and so on. But the other kind of pilferage is what we see more routinely, and that pilferage is of the quantity of health products that are purchased by, let's say, the government of a country.
Yeah.
Are they systematically reaching the health clinics, the hospitals, and the health posts, or are they getting diverted to other channels, such as being sold in the private market? And that pilferage, at least historically, used to be quite common.
Okay.
Some new measures have tried to reduce that kind of pilferage, but I think we need much more work there, including things such as tracking, civil society accountability, information systems that can help us understand the flows of what's coming in, what's going out, and so on.
Yeah, that's really insightful, Dr. Prashant, and I think that talk about global supply chain security is really a huge determinant in adequate medicines and supplies in a lot of low and middle income countries. We celebrated World Creativity and Innovation Day this week, and in an op-ed in the New York Times, Dr. Tedros of the WHO said scientists developed several vaccines for COVID-19 in record time. Yet of the more than 890 million vaccine doses that have been administered globally, more than 81% have been given in high and upper middle income countries. It's stated that low income countries specifically have only received 0.3% of the vaccines. Why do you think that is? And what do you think should have been done differently despite the initiative of COVAX?
Yeah, it's an important and pressing issue, Manumat. So I think, firstly, we have to put this in a larger time perspective and ask, have we done better than before? Right. So in previous instances of whether it was an epidemic or a larger pandemic or even an outbreak where we had a technology developed for effectively treating, taking, or managing that condition, how long did it take before low and middle income countries started getting access, even though I'm going to get to your question of how much. So in that sense, I think we've done much better, right? Within the first 7-8 months, of a new technology getting approved in one country, we already have in 5 months' time the product registered, available, multiple vaccines available in a large number of countries. In fact, I would say majority of the countries in the world. Then comes the question of where can we do better, so that in 5 months after a new technology is developed and approved for health, it is not the kind of inequity that we're seeing now. And that, in my opinion, requires two things. One is we need to have a very hard look at our manufacturing networks, and where are things produced. Where there is a concentration of manufacturing, that's not necessarily a bad thing, because when you want to make something at scale, having a plant that can make billions of doses sometimes gets you the ability to make it at a price that becomes much more affordable for everybody. But at the same time, we also have to ask the question, can we afford a manufacturing network which does not have nodes in some regions at all? And that would mean countries in Africa, countries in Latin America, which don't have a vaccine manufacturing network for some of the newer COVID vaccines. What can we do to make that work better next time around? There are constraints to it. There are things which are very doable. When we say constraints, every constraint is solvable if we put all of our energies, our resourcing, and our creativity together. It's not an unsolvable constraint. We can solve it. So that's the first part. The second is, of the total number of doses that have been produced or are to be produced in the next few months, are we at least allocating them in the right way? And yes, COVAX is trying to do that through the COVAX purchase agreements with those manufacturers who are a part of the COVAX supply arrangement. But at the same time, we need more from the high-income countries in accepting the idea that I don't have to necessarily vaccinate every single person in my country before I can allow vaccine doses to either be exported or vaccine doses that I have contracted to be reprogrammed or reallocated to other countries in the world. And accepting that is not just a matter of what political leadership in a country can do. Political leaders do what constituents want them to do in some ways, right? I mean, many of them will poll and ask, if I was to start sharing vaccines before we achieve 60% coverage in our country, would people, would that create a positive vote for me or a negative vote for me? And if the population says it is a negative thing, then very few political leaders will take the bold steps of exporting or of reallocating their doses. So I think we need a somewhat of a grassroots movement to build that kind of understanding that a country trying to vaccinate every single individual in boundaries isn't the right way to deal with access to health technologies, in particular during the times of a pandemic, but even more generally for infectious diseases in general. And that understanding is wider and bigger than the tactics of supply chain management that I work on, or the kinds of things which are about supply planning, manufacturing. We can solve the technical problems of manufacturing, distribution, logistics, procurement. But in order for those solutions to work and be sustainable, we need both a wider political leadership to accept this is the way things will be run, and in addition, or perhaps even a precursor to that, a wider population level acceptance of the idea that equitable access is what gets all of us to be better and safer.
Dr. Yadav, just a clarifying question there. Here in the United States, Johnson & Johnson and Merck are working together. That is an example of manufacturing network within a high-income environment. You're saying such a system must be copied and pasted throughout the global health, where this these vaccine formulas are sent to manufacturers in India, in Malaysia, in Africa, and the local manufacturers manufacture those vaccines at scale.
Yeah. So, firstly, what you described, Ashwin, of Merck and Johnson working, or BioNTech and
Yeah,
Novartis working together, or Sanofi working with Pfizer. I mean, we've seen numerous examples of companies coming together and saying, we'll allow our production capacity to be used to make your vaccine. What we've also seen are arrangements where, let's say, AstraZeneca working with SK Biosciences in South Korea, or with the Serum Institute in India,
yeah,
or Johnson & Johnson working with Biological E in India, or AstraZeneca working with vaccines in Argentina. Lots of examples like this,
yeah,
where the company which developed the vaccine has found a manufacturing partner and has voluntarily licensed their technology to be manufactured in an alternative location. I think we need more of those, right?
yeah,
And there are limits to how quickly we can have more of those for certain health technology platforms that are new. But in the case of vaccines, our lens is very quickly narrowed towards the messenger RNA vaccines.
right,
So we need to think about what are the additional sites which are ready to do the kind of partnerships that we've seen happen. And if there is a dearth of such sites which can receive such technology in some regions, so
yes,
if you say, well, there isn't a site in Africa which can start manufacturing um, the two types of vaccines
yeah,
that
yeah,
seem to be,
yeah.
can we build them? Same thing in Latin America. And I
Right,
think another part of it is that I think while the focus is a lot on vaccines, it's also important to think about therapeutics and what has happened there and what may happen there in the future. So an example is remdesivir from Gilead. Right? Yes, there are questions about the efficacy for reducing severity of mortality, but the product is in extensive use in India from 6 or 7 companies who
yeah,
received voluntary license to transfer that technology from Gilead to those companies. They are now producing that product at scale, oftentimes at a volume level that is much, much higher than what Gilead is producing for the jurisdictions in which it is serving. Right?
right,
So that's the kind of model which we want to see in more places. And in doing so, we have to ask very rigorously, what are the sites where we can do this?
right,
And that requires having the right equipment, but most importantly, that requires having the right team of scientific people who can help produce new health technologies. And oftentimes that becomes our biggest constraint, and that's not a constraint which is easy to fix or surmount, because that rests on having well-trained people
yeah,
in the country, in the region.
yes, true.
Yeah, that's it's definitely interesting how you've mentioned the role of collaboration, the role of feasibility studies, like just checking market visibility in the different regions, in creating those collaborations and partnerships, and even just the technical expertise that is needed. You had also mentioned a point previously about political will, which underscores every technical expertise you said. Like there's this saying in the business world where they say culture eats strategy for breakfast. So in this terms of political will and getting grassroots buy-in, still on this issue of vaccine equity, how would you try to garner support from the grassroots, from people from high income countries, to see the need to just be on that train to ensure that there is equitable access to vaccines across the globe?
Yeah, so I think for people in high-income countries to accept that the future state of the pandemic, in a way, depends to a large degree on how quickly can we suppress infection in countries which have relatively poor access to vaccines today. Because otherwise, we'll keep seeing new variants of concern emerge, not so much from the geographies that someone is living in and that where a large fraction of the population has been vaccinated, but those variants of concern will typically come from regions which are under-vaccinated, and that is clearer to some people, but a grassroots movements to make that understanding widespread is what will create greater political support. And to take what you said, Manganat, about culture eats strategy for breakfast, I think I would, after 2 decades of trying to do supply chain reform in low and middle income countries, I would make that equivalent statement, which is political economy of health systems and supply chain reform eats technical solutions for breakfast. I can build very clever technical solutions. And when I started in this journey of health supply chain reform projects in low-income countries, I used to be the person who was super enthusiastic about my simulation models and my trial studies and my analytical modeling work. But over time, I've come to the conclusion that those can be fantastic tools if they can fit under a meta structure which is supportive. People, institutional support, a champion, a political leader who supports it. And oftentimes we've also found that youth associations and civil society that consists of young people in a country who are keen to bring accountability become very good partners in building the momentum for reform. And that forces the leadership, the political level leadership of the health ministry or even other adjacent ministries to say, yeah, this is important. All of our young people are behind this. So we should start putting our stock information in the public domain, or we should start showing how much we are procuring, etc.
Okay, I just have like a quick question. Like once we're talking about this issue of low income countries having a lesser percentage of the total vaccines produced, so do you think like there must be some international guidelines or some international body which governs all these things about how the vaccine distribution could be done in an equitable manner? Do you have any insights about that actually?
Yes, Keshav. So how is distribution done in an equitable manner? And that is currently the role that COVAX plays. The core principle is that healthcare professionals and frontline workers in all countries should be protected first, and that is approximately, let's say, 3% of each country's population. So we should try and get 3% to all countries equitably, and then go to the next target level, which is 20%, and the 20% means those who are at the highest risk in a population, and so on. So yes, we have the principles, but how do you make everybody to adhere to those principles?
Yeah.
Is there a global governance structure which has influence, legal authority, or some kind of jurisdictional power to make that happen? That's not the case. Every country can choose to buy more, buy less, vaccinate different groups, etc., which is, in a way, the right way to do it as well, because you can't tell a country that, oh, you can only buy the supplies that we are providing you through this globally coordinated mechanisms. If they do find a bilateral deal, they will go ahead and do a bilateral deal. So we can't tell people don't do a bilateral deal. But I think where it becomes more challenging because of this structure is we lose the information to coordinate across different manufacturers and different purchasers, right? So think of a supply chain, Keshav, which is multiple producers and multiple buyers. And the only way such a supply chain reaches some level of efficiency is when the matching occurs based on better information available to all the buyers and all the sellers. Like, we're not saying release your proprietary, commercially confidential information, but if a company which is manufacturing vaccines has an order book, and that order book is clearer to another buyer who's placing the order. Because if they don't know about that order book, if they don't know that a bigger country has placed an order and the manufacturing capacity is such that this manufacturer will not even be able to deliver anything else but this country's orders for the next 8 months, then they may be under the false impression that by taking their order to this company, they will get more vaccine supplies over the next 6-7 months. They won't. So it's this information to coordinate a multi-to-multi sort of supply chain, and creating a better information network is the need of the hour. It's not, once again, easy because, we all like to say that, yes, we would like to coordinate and share information about how much I bought from which manufacturer, but people have a busy day job. So that is only a hobby that someone can pursue, saying, okay, I will coordinate this. Unless it is explicitly made the job of some people to say, you will be every day or every week or certain frequency of time looking at all the orders that each agency is placing, and such people need to be then based across the different groups purchasing and selling. And then they keep sending such information back into some kind of a technology network. That's where our problem can get solved. But the incentives to do that have been weak so far for some reason, which is sometimes beyond my my level of rational understanding.
Yeah.
So that was actually quite interesting and gave me a better insight on it. So, and one more question, talking in a more supply chain perspective of how this vaccine distribution and all the sourcing kind of things happens to a manufacturer. So right now, since the COVID has started since 2019, there have been a lot of reforms in the international trade laws and global trade actions. So these things have gradually caused an impact and disruption in lots of the links of the supply chain. So people had a basic definition of a resilient supply chain before 2019. And do you think that because of all these trade laws changes, and even for say the latest Suez Canal blockage, which caused a huge block in the logistics network, so do you think that you might need a redefinition of what a resilient supply chain should be in future, considering all these new changes which could happen?
Yeah. So you study global supply chains, Keshav. So you will appreciate the fact that whether it's vaccine manufacturing or it is the manufacturing of therapeutics or other medical devices or equipment,
Yes.
the supply chains are intrinsically extremely global. And when I
Yes.
say extremely, I mean components and parts and sub-assemblies, or specific chemicals and active ingredients and finished products and excipients are flowing from across continents, across countries. And you may say, that's just a function of people trying to optimize the supply chain for labor laws, or sorry, for labor costs or taxes. And that may well have been the reason why it started. But today, the reasons for why the supply chains are so globalized and there are so many nodes in the supply chain has to do with where specialization has started occurring, right? So there are parts in China, there are parts in India, there are parts in northern Italy, there are parts in Germany or in Luxembourg or in Belgium, which have become specialized about making some kinds of items that go into manufacturing either medicines or vaccines or medical products or medical equipment.
Okay.
Now we cannot change that overnight, but in the quest to say, can I get everything for my own country, we have seen trade blockages since April of the last year, so April of 2020, initially for PPE, other kinds of supplies, and eventually more recently for either vaccines or key ingredients that go into vaccines, including equipment that is required to manufacture vaccines. Right? So then as you pose, is that going to mean that we will change the laws of how supply chains are organized? That would be your question of would resilience be measured with a slightly different lens?
Yes.
So I think the laws. I mean, if you think of the laws as almost like the laws of physics, they are not going to change. Adding a layer of messy politics and messy trade politics on top of that will at best force people to have some reactive capacity to say, in case the global link doesn't work in the future again because we see a similar trade blockage like what we've seen in the past, at least we should have more reactive capacity. So it will become a combination of getting your routine large volume purchases still through the systems of global trade, but in addition having some reactive capacity in case those systems face blockage. Again, it's hard to predict where we will land with this, but I think national governments should take a slightly different view on this than what they have, in my opinion. And that view would be, instead of forcing a company or a supply chain to say, if you want to serve our country with medical products, you have to base all of your production in our country, which is the approach we see some countries taking. It should be, can you guarantee to us that here are the 10 major risks that we foresee, and those risks include the risk of trade embargoes, they include the risk of natural disaster, they include the risk of other geopolitical events. Can you demonstrate to us that your manufacturing network will still be able to supply to us in case any of those risks become real? And then if a company says the only way I can manage that is by having a factory in the country's national geography, then so be it. But if a company says, look, we can meet all of your requirements by having only small capacity here, most of our capacity elsewhere, then so be it. Right? And that will lead to a supply chain network design that both respects the need for resilience as you described it, but at the same time also doesn't compromise efficiency, cost, affordability in a big way. Because in healthcare, I mean, yes, today we are in a position that we say we are willing to spend a lot more, but historically as a society, nowhere in the world have we been able to say that this is something we value and therefore we should, pay in conjunction with what value we associate to public health, for example. So there is a risk that we may go back to it, and then the only way that gets solved is that we maintain the affordability and resilience, and in a way we can use creative methods to shift the efficient frontier on that. Right now I'm saying there is a trade-off, and that trade-off is that if you try to build more resilience, maybe you may end up compromising the affordability aspect. If you build more affordability, maybe you're compromising resilience. But there are some models in which both can be done together, and that's what requires ingenuity and people like you who study supply chain to come out and say, here is a model which allows us to shift the efficient frontier to achieve both of these together.
Okay.
And to audience members joining in, we are talking with the distinguished Dr. Prashant Yadav on the future of global health supply chain opportunities and challenges. I would like to remind and encourage audience to ask questions. This is your time. So, Dr. Yadav, tomorrow the world celebrates the World Malaria Day. And what is one huge lingering concern you have when it comes to malaria supply chain and defeating the disease?
Yeah, thanks for bringing it up, Ashwin. So one is that we have made tremendous progress on multiple fronts related to malaria. The supply chains that deliver mosquito nets to large parts of the world population have started working in a much better way than they were 10 or 15 years ago. The idea of public-private partnership in running those supply chains has also become exemplar. We can do more, but it's become much better. So that's on mosquito nets and prevention technology, right? So ways to prevent malaria, same thing with residual spraying and so on. that when it comes to the supply chain for treatment, which requires, well, diagnosis and treatment,
Yeah.
those are the supply chains which are still embroiled in not having sufficient information about where are the medicines needed, having routine stockouts of malaria medicines. And the solutions, once again, are about building a better information architecture,
Yeah.
building a better supply planning model,
Yeah.
which we all know. I think there are many studies, many projects, things like that, which people have done, including some by me and colleagues. So that's one area that needs to be addressed. The second is that we also have to accept the idea that treatment for malaria is like what we see in the retail world as omni-channel. Some
Okay.
people want to go to a private pharmacy. Someone wants to go to their little kiosk. Someone wants to go to the nearby private clinic, and someone wants to go to
Yeah.
the nearby public hospital or clinic. Right? Wherever people choose to go, they should be able to get the medicines, and they should be able to switch between channels. Right? Today, my preference is to go to a government clinic. Tomorrow, my preference is to go to my pharmacy. I should be able to get a malaria medicine no matter where I choose to go. And
Yeah.
building omni-channel structure for the supply chain for malaria medicines, once again, rests on a very strong and robust information architecture,
Yeah.
which we are missing. And the third thing about malaria is that we are starting to see at least some positive developments on malaria vaccine. You would have seen the
Yes.
results that came out from the Oxford and Novavax
Correct.
trial. There are other things like the current RTSS vaccine. So we may reach a point soon where we would have more tools against malaria, and then it'll once again be a question of, is our supply chain ready
Right.
to get those tools out
Yes.
quickly
Yes. Mhm.
and effectively to everyone who needs it? And that's what we all ought to be focusing on, to build the supply chain to be ready for when we have the malaria vaccine, so that we don't have to start the planning afterwards.
Yes. Yes. Absolutely. Well, this is truly insightful, Dr. Yadav, and we are really curious about your own life and how you came about to this field of global health supply chain. If you can discuss with us what maybe childhood experiences motivated you to doing what you're doing today.
Yeah, so it's a combination of childhood experiences and experiences later in life and circumstance, right? So I won't call it a very planned journey, but the combination of those three things. So I grew up in India. Everywhere around me, including members of the family, worked as physicians in public sector. And I remember visiting some of the what were then called as the block medical officer. So that's sort of a level of the government that is below the district.
Okay.
And seeing how the system operates. And even though I was somewhat privileged in the kinds of hospitals and pharmacies that my family would go to, and what you would see when you visit your uncle, who's the block medical officer, that stark difference starts to stick with you. And for a little while in your youth, you accept it. You say, "Oh, that's the way things are." You start to sort of internalize and not question that. And then as you grow up, they come back and you get hounded by those questions as to, you saw them when you were 8 years old, and then when you go visit back when you are 40, you still see them. And that's the point where you say, well, I haven't done anything. This is still the same. So that's one about experiences from childhood. The second is that different people have different paths of training and how they come to public health. Like I described, I know of colleagues who trained as architects or civil engineers and have since then become deans of the schools of public health or biggest contributors to global public health in some ways. So my own training was in engineering and in operations research and management science. And most of what I started working on as a young researcher was focused on analytical things on forecasting new product demand for pharmaceuticals in the US, or building plans for matching demand and supply for new medicines in North America and occasionally in Europe. And as I was doing that, and some part of my work was also in consumer product supply chains and fashion and other kinds of supply chain things, but that was still a smaller part. But all of that kept reminding me, is there a public element to supply chains? Because most of my peers were focused on supply chain to be a firm-centric thing. It is a company that runs its supply chain. How can I help this company run its supply chain better? So that we have more of the consumer product in the shelves of the retail store, or we'll have faster fashion garments in the store of the fashion retail store that we go to, etc.
Yeah.
And that sounded exciting for a little while, I admit that. But over time, it wasn't neither intellectually nor morally satisfying.
Yeah.
And that's when I, through, again, this is now through a little bit of circumstance, that a few colleagues invited me to, so I did some work on flu vaccine supply chains in the US in 2003 and 4, which was the year where we had a big shortage of flu vaccine in the US. That was my first direct involvement in looking at this from a public policy lens. And then through that work, some colleagues invited me to get more involved in malaria medicine supply chains. And that was, once again, a side hobby project. And I thought, okay, I'll do some of it. And over time, I realized that's mostly what I do now, because it has been just a very rewarding journey to be able to contribute to this.
Fantastic. So inspiring.
Yeah, it is inspiring. So could you tell me as someone who's graduating from supply chain management, so what do you think is one skill that someone needs to particularly develop to have a confluence between supply chain management, global health, and so that one can have an all-round picture of what's happening?
I think you're on mute, Keshav.
Keshav, you got muted.
Oh, sorry. Did you hear it before? Or
I heard till you said, what is one skill that people can develop when they graduate?
Okay, yeah, sorry. So yeah, I just wanted to ask, what is one skill that someone like me needs to properly develop to have a confidence between his technical skills of supply chain management and the human aspects of being in global health? And is there someone that you admire who has something like that, or someone whom you've seen that in?
Yeah, so firstly, I think I would say deep analytical knowledge in supply chain management is useful to have, no matter which field area you want to contribute to. Even if you, and I won't hold it against someone who says, I want to apply that to get Amazon products quicker, faster than they already come to my doorstep every day. That's also contributing to society and creating some value. But I think the part that I want to encourage you to think about is supply chains and the social benefits that they create, or in some cases, the social costs that they create. That's often missing from the lenses of, at least I've seen that from students who've been part of programs I've been associated with, and as they graduate, there isn't a way to say, well, my training in supply chain management has a strong social component to it. If I do it right, society will be better off. If I do it wrong, society may incur a higher cost. First is that lens. Healthcare, no healthcare, that's the first lens, which is, are you honoring the social contract of supply chains? And I argue that supply chains have a very strong social contract. We are a function that is meant to deliver the right kinds of products to people without them being too expensive, all of the things that come with it. Then is a question of health, and I think health is an area where there are two levels at which supply chains operate. One is if you work for a pharmaceutical or a global life sciences company as a supply chain person, then yes, you are very intertwined into the healthcare system and supply chain management. That's one way of thinking about it. But then your view is still firm specific. You are working for a large company and are thinking, how do I contribute? The other is, as a supply chain professional, you go into some kind of public service. And public service doesn't mean you work for the government of a country, which is also a very important area if you like to explore that. But there are many other channels. And that, I think, is, once again, a somewhat unexplored, uncharted territory. There are very, very few of graduating supply chain professionals who take that path. We haven't even made it easy in global public health for someone to come and join, because I also know people who say, I want to contribute, and we don't find them the right places to get started. But at the same time, I think if there is a greater movement amongst graduating supply chain professionals of, I want to contribute, and we can track their pathway. I've had students in the past who said, I only want to go in public service, and I would not want to go and work for a firm, and they did very well, became ministers or vice ministers in their countries, did very significant public service roles. So I think we have to create more examples of supply chain professionals. One will not help, because you may relate to that one and another person may not relate. But we need hundreds of examples so that anyone can say, to my persona, can I find someone like me who took the path of public service and supply chain management and made a mark for themselves and became successful? And that's the pathway I want to take. So that's the journey we're still on, and trying to create such exemplars.
Okay.
So for our audience that are just joining, we're speaking with Dr. Prashant on the future of global health supply chains in public health. So as we're quietly rounding up now, please feel free to ask your questions and comments. And Dr. Yadav, we do have an audience question. So it says, with some potential high degree of vaccine hesitancy, which we've seen around the current pandemic, what adaptation, and I believe this was made or should be made, to ensure quality vaccines do not go to waste or expire on the shelves or lose potency?
Yeah, so if you think about how supply chains for vaccines are run for routine immunization, so not so much for COVID, but for routine vaccines, right? We run a system in which we purchase, we store them in a central warehouse. Then, once a week or once a month, we distribute them from the central warehouse to a second level storage point. From that point, then we take them out and distribute them to the vaccination centers or the clinics at which we vaccinate. Because we don't want to have wastage, and we have vaccines for COVID which have limited shelf lives. Yes, we can re-examine what was the basis for setting up that shelf life, and perhaps we can have extensions, which we are starting to see. But even if we assume this is the given shelf life, we want to run a faster system. And by a faster system, we mean we don't want to keep the vaccine sitting in a warehouse for long. We want it to be moving and then quickly getting administered. And that requires a supply chain which has fewer layers, which is more direct. It goes directly from the point of purchasing to the point of administration. It goes more frequently. And sometimes having mass vaccination sites also helps, because that way you can very quickly use supplies.
Yeah, that's really insightful, Dr. Yadav. I think now we're on the hour, so we want to respect everyone's time. Thank you for really shedding light on the future of global health supply chain, talking about how we want to create resilient supply chains and finding that true balance between, creativity, innovation, and finding impact, and making sure that there's, equity in access to vaccines and medicines and therapeutics and diagnostics, not just for COVID, but for other disease conditions, and trying to ensure that, you had talked about political will, eating technical solutions for breakfast. I dare say it would eat it for breakfast, lunch, and dinner if we don't incorporate some of those, personnel management and human interactions and interpersonal relationships into the work that we do. So thank you so much for highlighting that For our audience who are joining us again, we've been talking with the phenomenal Dr. Prashant Yadav on future of global health supply chains, not just in the era of COVID, but for the future of global health and healthcare in general. And for everyone who has family or friends or anyone in India that is going through this trying time now, we say we're all with you. We're hoping for a solution and resolution to this global pandemic. And as Dr. Yadav had said earlier, nobody is safe till everyone is safe. So basically, as a world, we are united in trying to combat this pandemic and making sure that we can find solutions. Dr. Yadav, you had mentioned something earlier about how there are unconventional paths to really trying to address global health challenges. And you had mentioned this platform and this channel being one of those ways that we try to not just encourage emerging leaders, but just shed light on important global health topics. What other advice do you have for any of our audience who is really burdened by the current pandemic and is trying to find a way to support?
Yeah, so I think local action starts with building a coalition of people around you who are willing to contribute, and then finding an agency, a person, a champion in the public system who is willing to get support from the outside. And both are not easy tasks, to build a coalition of people around you who are willing to work with you. Because if you as an individual say, here is what I want to change, there is not going to be as much traction. So you build a coalition of people around you, but then it's also the next task of convincing someone in public administration to say, yes, we can get your help in how to organize our mass vaccination sites, or we can get your help in how to run the queues for our testing site, right? And I'm describing very operational examples of places where such operational expertise is needed. Or in some cases, can we put the best minds together to help us forecast the needs for PPE in our district or in our geography, or perhaps even sometimes even in our hospital? How much PPE will we need? Those are the kinds of things which I feel people can contribute. Again, the situation in India now has gotten to a point that the opportunities of doing something like that may be, at least in the short term, minimal, and it may largely be about finding or being honest information brokers between sources of supply, and supply being whether it's oxygen, medicines, bed capacity, etc., and where demand is. So, acting as honest information brokers. But in the medium term, the kinds of things that I'm describing would be the way to contribute. At the same time, there needs to be a forum which brings together like-minded young people who come from diversified disciplines. So we're not necessarily someone who says, I trained with a graduate degree in public health and my pathway is clear. Most people who come to my MPH program, this is the kind of jobs they take. I'm not talking about those, but I'm talking about those who are passionate about contributing to public health, but trained in something very different. Can there be a global or national fora for people to come together and learn from each other's pathways? And I haven't seen any like this, so I also encourage you to think about exploring that.
Thank you so much, Dr. Yadav, and what a way to end with that call to action. For our audience, thank you for your patience and for your interaction and engagement. I know a lot of our audience would want to reach out to you after this, Dr. Yadav. So what are social media handles or other means by which they can connect with you?
Yeah, Twitter and LinkedIn. I don't know if there's a way to share my Twitter handle. It is Yadav_supply CHN, or on LinkedIn, and I'm happy to connect, hear your comments, critique, your war stories, or things that you are trying to do, or areas where my knowledge has gone the wrong way, and you have ways to correct that. All of that.
Well, Yadav, it is an honor and pleasure to have you. We are really humbled to talk to you today and to really learn about all these insightful experiences that you have got, and thank you for sharing your time with us.
Thank you for hosting me. Thank you very much.
Appreciate
Sure,
it.
thank you.
Bye, everyone. Stay safe and be well.
Bye. Thanks.